This video is about a robotic reversal of a room-wide gastric bypass for malnutrition. These are the disclosures for the authors. Reversals for room-wide gastric bypasses are rarely performed. Malnutrition is the most common indication of reversal, followed by dumping syndrome and excessive weight loss. Our case presentation is a 52-year-old ago, and she dropped to a weight of 48 kilograms. She developed gastrocalcium anastomosis, was advised, and we placed a G-tube. Her weight came up, but 6 months ago she dropped again to a BMI of 14.8. Became severely malnourished, and she dropped her weight down to 36 kilograms, which was a BMI of 14.8. We placed a feeding tube, and we were able to increase her weight to 48 kilograms and planned for a gastric bypass reversal. In this case, our operative plan was to robotically reverse her gastric bypass, but to use all of her small bowel length, so to make a gastric anastomosis and to preserve the roux limb. Here we start the operation by already have taken down her G-tube from her remnant stomach. We're taking down the adhesions near the hiatus so that we can mobilize the gastroesophageal junction as well as the gastrojejunal anastomosis to resect it. We have found that the best way to approach these cases is to divide the mesentery of the roux limb early so that when we do so, we can use it as a handle, and by dividing the mesentery, it will cause an ischemia so we can see where the delineation of the jejunum and the gastric pouch is. Here we use ICG to also help us determine this. As you can see, it's already becoming ischemic, and there's a small bleeder there, but it's already becoming ischemic, so that guides us in our resection of the gastric pouch. At this point, we have to perform the gastric anastomosis, and I was originally going to do this stapled, but I found with the tissue thickened the way it was and the way that the stomach was adjacent to each other, that it would be better to do a hand-sewn anastomosis with a very wide anastomosis. We used Stratafix for this, which is an absorbable suture. There's also a concern of stapling multiple times over the stomach and causing an ischemic bridge of tissue where the staple lines are adjacent to each other. Therefore, a hand-sewn anastomosis was more versatile in this case and a safer option. Once the gastric anastomosis is performed, the ligament of Treitz was identified. We placed a bowel clamp and performed an air insufflation leak test with an endoscope. At this point, we run the entire roux limb, which was very long, in this case about 130 centimeters. Once we reach the jejunal anastomosis, we are able to identify all the limbs, including the biliopancreatic limb. Here, the only piece of the bowel that we've cut is the roux limb, so we're just identifying the limbs correctly before dividing anything else. Again, it's very important to identify the ligament of Treitz and to not divide the wrong portion of the bowel. So here we've identified the biliopancreatic limb, and we're going to run this back to the jejujejunostomy so that we can divide the intake of the biliopancreatic limb into the jejujejunostomy. When reversing a gastric bypass and we're not trying to preserve bowel length, we could just divide the roux limb at this point and the operation would be over. However, since the patient has such severe malnutrition, we want to identify everything and preserve the roux limb. So again, the bowel is run so that we can orient ourselves in space. Once we have positive identification of all the limbs, we then divide the biliopancreatic limb where it goes into the jejujejunostomy. I mark the biliopancreatic limb with a suture to keep myself oriented in the body. At this point, we divide the mesentery that is holding up the jejujejunostomy. so that we can then divide the extra piece of small intestine off of the former jejujejunostomy. The bowel was very dilated and patulous, so at this point we decided to just go ahead and divide that portion off of it, leaving the rest of this intact. Otherwise, we would have had to make 3 anastomosis instead of just 2. Once that's divided, that becomes portion of the common channel. And then at this point, we have to identify the 2 cut ends of the small bowel and align them appropriately. The easiest way to do this is to follow the mesentery of this bowel, as it should be continuous. Once we've got the mesentery identified and oriented, we can then perform a small bowel end-to-end anastomosis using a white load of the robotic stapler. This anastomosis is large enough to accommodate a staple technique, so that's what we performed. The mesenteric defect is then closed, and we run the bowel a couple of different times just to make sure that we did indeed perform the right anastomosis. The bowel is in continuity again. The gastrogastric anastomosis has been created and is secured, and we run the bowel just to check everything. We take down the portion of the stomach where the G-tube was, and then we place the specimen into a bag and remove it. If the specimen breaks open during removal, this can cause a serious soft tissue infection, so I do place these in bags. The 12mm trocar site is closed, and then that completes the operation. The patient tolerated the procedure well and was discharged home on postoperative day 1.